I'm a chronic disease nurse and have lots of patients with COPD, diabetes, and heart failure. They are so COVID vaccination fatigued. So the questions they commonly ask is how important is it for them to have the RSV vaccination? And should they still continue with the COVID vaccination? And how often?
Look, I think it's really important, and I think it highlights, exactly some of the challenges that we're facing at the moment. And, I get a lot of people come back to me and say, but I've had 2, 3, 4 COVID vaccines. And I think that narrative has to change about the number we've had. I mean, I often joke back to those people that we don't have people coming in saying, well, I've had 37 flu vaccines. I don't feel like one this year. We gave up counting those a long time ago because we know it's just something you need to do regularly. And I think with COVID, and particularly if people have limitations on their ability to respond, that the narrative there isn't, well, it's no point. It's that you probably need to do it more often. And because that same reason that you're likely to respond less well than someone who's 25 is the same reason you're more likely to have an adverse outcome if you were to get infected. So, obviously with RSV, that's a relatively new vaccine. It's approved from 60. The ATAGI have recommended it from 75, and it's sort of a consider below that. But I think if you've got other comorbidities that put you at high risk, and we know, and I very quickly flashed up the COVID sort of risk profile, but with RSV, it's similar. A lot of those same comorbidities are ones that will contribute to the probability of having a worse outcome. Then they're probably exactly the groups that should be getting that vaccine, I would think.
Van Binder.
Look, I agree with what Professor Griffin was saying. I mean, I think, most of us are very frustrated by the degree of vaccine fatigue, hesitancy. I think what Paul's saying about let's stop counting how many is really important. People feel that they've had enough, whereas really what they need is they need more. I'm very disappointed in the ATAGI recommendations because it's only age-based. It means that we're not actually getting messages out to people that if you're pregnant, you need a booster. If you're about to go traveling on one of those, Petri dishes called an aeroplane, you need to have a booster. And if you're a healthcare worker, it's immoral for you not to have had a booster and make sure that you're protecting patients. So I think we've just got to get back to a stage of saying that we have groups of people who suffer very badly if they have infectious diseases, some even worse than others. We have a need as healthcare workers to protect them to the best that we can. And that means having discussions about that, this isn't a numbered process or anything else, that we have more and more better vaccines and that we need to make sure that you're getting them, particularly if they're the sorts of people that you talk about.
Michael.
New vaccine's fantastic. Yeah, loudly. New vaccines are fantastic, but this week we've had an outbreak of influenza and whooping cough in one of our residential care facilities. Maybe we've also got to remember about some of the older ones because the effects are just the same, and you can grind, the health system to a bit of a halt, given that it's so frail itself.
Thank you, Michael. I've been a long believer that failing to fund pertussis boosting in older persons is a big problem again with our vaccine program. And there are data that suggests that the mortality of pertussis in older persons is actually worse than the mortality of pertussis in children. But we have a huge focus on pertussis in children, particularly in the first 3 months of life, which I agree with. But I think there should be a funded regular boost, and it's probably closer to 5 years than 10 years for pertussis in older persons. And, there was that great study of those nuns in Belgium, where they'd coughed for, well, as they say, the 100-day cough, but where they coughed, and I think 3 of them passed away, and people had strokes from the amount of time they were coughing. So pertussis is an unrecognised but really important disease that we can prevent in older persons. It's just a pity that we need some newer vaccines for pertussis in the same way as we need them for others, because this is not, immunogenicity for a long time.
I've got a couple of questions online on the microarray patches, the MAPS. What evidence is there for the durability of the immune response when using a MAP? How long does the immunity last? What do you know about that?
So studies, the longest ones that have looked at the immunogenicity last up to 180 days. However, most of them, I think, stop looking at about 40 to 60 days.
So this is a space in which we need more evidence. Another question, what about the potential of anaphylaxis, where particularly if you're self-administering?
Yes. I can only say that hopefully they're being monitored by a clinician, and
I think that's a concern with self-administration at home, and obviously that's what a lot of people want. So there have been conversations about telehealth and whether, using perhaps a booster vaccine in patients that have shown no previous anaphylaxis. But yeah, it's obviously a concern.
I have a question for my colleagues on my right. I don't have any great belief that needle phobia is contributing to our vaccination rates of less than 10% in children 0 to 5 in some places in Australia. I mean, we managed to get 95% using needles for other vaccines. And so I think that, I see more concerns about needles in the mothers and fathers than I do in the 6 weeks babies that they're holding. And so, what I'm most interested in microarray is whether I'm going to get a potential improvement in effectiveness rather than, this technology leading to a decrease in people who have to have a needle.
as I've mentioned, so far it shows that there's either a similar, maybe a little bit of a better immune response. However, it's important to note that it's not just the lack of a needle that is a benefit. There's the reduced risk of sharps, and there's enhanced thermostability, and as well as ease of use. So it could be self-administered. And as we discussed, there is a potential for mass administration. So if we're unfortunate enough to get another pandemic, or even endemic situations, we can get potentially a group of 20 people being supervised by one nurse. And hopefully that's
And I agree with your comment about the parents, but the parents are the ones that provide consent for the babies. It's generally the baby doesn't know, or little toddlers do sometimes after they've had a few. But it's the parent that provides the consent, and often it's the mother. And so it's actually working with the parents and getting their sort of acceptability and usability. I also think there's a lot of potential in the adolescent market, particularly in the school-based immunisation program, where there's some sort of refusal there. So, but I agree with your comment broadly, and it's about bringing on other key stakeholders who are providing consent for their child. Yeah.
Okay, one more question to pool number 1 and pool number 2. I might have missed it, but can you please advise about the immunogenicity between the 2 RSV vaccines, the one with and the one without adjuvant?
I guess I showed the immunogenicity or the efficacy from the trials. We always have to be careful comparing different rates because obviously they haven't been done in a properly designed head-to-head study. Like a lot of these vaccines, the important thing is to get the one that you can. They both have high levels of protection and safety. And that's obviously a given they're approved in our country as well as elsewhere. So yeah, I'd be cautious comparing them, but just to know that the efficacy looks great between the two.
And what about giving Arexvy alongside other vaccines on the same day, Paul?
I'd be comfortable in giving Arexvy. I mean, we had a discussion earlier about 2 adjuvanted vaccines at the same time and why there's some degree of caution, but really no specific risk. And I agree with what Paul Griffin was saying. Both of these are, well, the 2 currently available or soon to be available on July the 1st, and the third one, which is getting ticked by various regulatory bodies at the moment, should be on the Australian market as well by the end of the year. So there are 3 RSV vaccines, 2 presented today, an mRNA vaccine that is imminent as well. I think they all show really good data from what we have. There's no long-term effectiveness trials or even great usage of these so far, but I don't think I would recommend one ahead of the other. If you've got access to one, then please use it. Please use it in all of our elderly. And I think that they're all a great improvement on where we are. And I don't think, you know, I mean, I don't say it's a conspiracy. I don't vote for Donald Trump, but the fact that all of these companies use different ways of classifying disease and serious disease and the rest of it makes it very hard, even with the data that we have, to say that I think one's better than the other or not. And I haven't been able to get consortiums of companies to agree on let's all get together and run a head-to-head study for some reason. I'm not sure what that is. Maybe the loser wouldn't be happy.
We better stop there. That's been a great first session. We're reconvening at 20 past, so time for a morning break. Thanks for your attention, and please thank the speakers.